I think that they are, despite the clinical evidence of massive responses to targeted agents. I think the sort of anecdotal evidence of exceptional responders with multiple targeted agents suggests that it is possible for glioblastoma to be addicted to an oncogene. Basically, the clinical data, as I said, would suggest that that GBM's glioblastomas would probably not be addicted because the overwhelming majority of clinical trials using targeted agents have shown that there's little evidence of clinical activity. So one of the things that we have been looking at for the last 15 years or so is to try to see whether this is due to really the lack of addiction in these tumors or because of other reasons. And some of the reasons that we came up with as potential explanations are, one, for example, is that most of these agents that we use do not effectively penetrate the blood-brain barrier, which means that you would not get the drug that you're using in sufficient quantities to elicit the desired biological response. And so what we found, for example, is that in the case of EGFR inhibitors, this seems to be the case. So we published a study a number of years ago now where we showed that Lapatinib, although it is able to get to these tumors, it gets to them in a concentration that is below the biologically active level of drug. So that's one possibility for why we haven't seen any responses. And I have to remind you that, the one of the major problems is that in current clinical trial designs, we don't really measure intratumoral concentrations of these compounds. So we just assume that they get there because there is breakdown of the blood-brain barrier in most of these tumors, but we don't actually have direct evidence of this. So the other possibility is that tumors may have resistance factors in place by the time these patients enter these trials. And so one of the things that we also published several years ago is that in glioblastomas with, for example, EGFR activating lesions, inactivation of the tumor suppressor PTEN is extremely common. In fact, it's more common in EGFR activated tumors than tumors with no EGFR activating lesions. And that that loss of PTEN is actually a resistance factor in this case. And we've published a study sort of discussing the molecular basis for that resistance. But it's not just, PTEN loss. It could be other loss of other tumor suppressors. It could be factors secreted by the tumor microenvironment that simply make the drug less effective. But this does not mean that tumors are not addicted to some of these oncogenic lesions. And so, some of what my lab is trying to do is trying to come up with a list of these potential, mechanisms of de novo resistance and try to use that information to come up with a better strategy for how to deploy these agents in GBM patients.